I think the first part of your question, in terms of changing the culture, requires showing doctors the variation that exists between them for the same diagnosis or the same procedure, and coming to some consensus about what is a reasonable standard of care, and coming to some consensus as to what is underutilization and what is overutilization of resources. And once we get to that agreement, let's say, for example, on endoscopies for any condition, and let's say we come to agreement that several or some doctors have overutilization, then we would have to agree that those doctors need to change their behavior pattern. Is that easy to do? No. I think it's very difficult to do. And I'm just picking one example. There are probably dozens, if not hundreds, of examples of things that we do for which there is variation. And we need to decide what variation is reasonable and what variation is unreasonable, and then rein it in. Now the second, and that's a big deal, figuring that all out. That requires a lot of good data in real time that can be disseminated to doctors in a way that's meaningful and not junk. In terms of the second part of your question, what resources are needed, the answer is a lot. Resources are needed, first of all, to get the data in a format that is meaningful for doctors. The data needs to be disseminated to doctors, which can be done in part electronically, but it also takes staff. It takes person-to-person time, face-to-face time, to sit down with groups of doctors in small groups and go over this, because this is information that may be new to them, and they may not like it. It may require change. It may require doing things differently, maybe doing less things than they did before, or doing them in a different way. So change is always threatening, and that's a lot of man hours, person hours. So I think the cost is very high, both in technology, administration, and leadership, in literally getting out to all the doctors and having these multiple conversations. Well, I think it's a little bit like learning to swim. And somebody says, jump in and we'll catch you after you jump in, and kids learn that at some point they have to jump in because mom or dad is there to catch them. And I think the doctors need, I'm not comparing doctors to children, it's not the point of the metaphor, but I think the point is that people at some point have to take it on faith that we're trying something different, that the old model is severely broken. The fee-for-service model, I've been saying this for years, is broken and drives costs up unnecessarily. And we've tried that for years. It's not working. So we have to do something else. Now, some might say that global payments didn't work either, and it's true they didn't for a variety of reasons. We could get into that. But to answer your question, I think that we have good faith with our doctors. Many of them have been in our organization for many years. We've been through problems together. We've been through challenges together. So this is yet another one. And it's about leadership, and it's about communication. And some will come along faster than others, and that's life. But part of our job as leaders is to educate and listen to those that don't understand or aren't happy, and try to bring people along in a fair and open fashion. It's a process of trust with patients. I've cared for my patients, some for more than 20 years, and I think if they have a different insurance product and they talk to me about it, I'm hoping that they believe I'm still providing the best care that I'm capable of providing to them, irrespective of what happened to the details of their insurance. I think it's harder for younger doctors who have a shorter timeline with patients, and they haven't built up that trust over years. So that's going to play out, and I think we're at a kind of a vulnerable time in the market as we try this experiment yet again. But hopefully it will succeed, and then success will breed more success. The biggest concern that everyone would have is that now there's a financial incentive for doctors to do less. And you know what? That's true. So the less ought to be a correct decrease in utilization. But the concern would always be, on my part, on any doctor's part, and on patients' part, that doctors would be incentivized, which is a word I never liked, but I'm now getting used to using, to do less than they should. And we have to make very certain that does not happen anywhere. I think these anxieties are totally understandable, and nothing stays the same forever. And healthcare in the U.S. in large part is a great success and a great failure at the same time. And the financial failure that's busting the budgets of the entire economy cannot allow it to go on the way it is. And so doctors have to recognize that change must happen. And they can either stick their heads in the sand and say, tell me when it's over, and take the consequences, or they can jump up and say, what can I learn and how can I get on this bandwagon and do something useful and productive. So I hope that more doctors are in the latter category than the former. It'll make life easier for all of us. But it has to change. It can't go on the way it is. I do believe this is the correct method of paying doctors. However, it has to be done fairly, and the budgets have to be set fairly, and the trend numbers have to be set fairly. The payers need to recognize that if there's inflation or there's medical inflation, we don't control that, and we doctors cannot be held responsible for that. If there's a flu pandemic and suddenly the utilization triples for 3 months of the year, obviously there have to be ways of dealing with all these details. So my answer is a very simple one. I've always favored global payments, but it needs to be done fairly, and that requires a lot of data and a lot of thought and a lot of work on both sides of the fence, the plans and the providers.